Hello again. In this lecture, we're going to talk about some special assessments that you can do, and some of those will include also the mental evaluations that you'll be asked to do for one of our first assignments. So let's start off talking about social determinants of health. And I alluded to this a little bit in one of the previous lectures when we were talking about the social history and why some of the social history is so important to gather. And it's not just, like I had mentioned, for us to be nosy, but because knowing some of that social information can help us to understand patients who are at risk, to understand what they are at risk for, and to understand how we can help them to be as healthy as possible. Social determinants of health are conditions in the environment where people are born, live, learn, work, play, worship, and age. So lots of factors there that affect a wide range of health, functioning, and quality of life outcomes. And we know this to be true. Nurses actually have been thinking about social determinants of health for a long time. I mean, I've been a nurse for 30 years. And when I was just a newbie nurse, new to the floor, one of the things that the more seasoned nurses taught me is, when I did my discharge teaching, that it wasn't just about teaching, right? It wasn't just about, okay, go get this prescription and take this medication and change this dressing. It was actually asking patients, do you have a way to get to the pharmacy? Are you able to afford these prescriptions? Do you have somebody who can help you with that dressing change because they can't change something on on their back or they couldn't reach it? It's all of these things. It's knowing where they live. It's knowing, do they have transportation? It's assessing, do they understand, right? Do they speak the language? Can they navigate the system? What's their medical literacy? And we also know that there can be two neighborhoods right next to each other and have a different life expectancy in those two neighborhoods. Social determinants of health, really important. And it's so important that this now has become mainstream and we're talking about it because, as I said, we've realized this for a long time as nurses. So some other things to consider with social determinants of health. The material attributes of a place, the patterns of social engagement, sense of security and well-being are also affected by where people live. Obviously, we know that to be true as well. Resources that enhance quality of life can have significant influence on health outcomes. Boy, is that true. We talk in terms of availability, not only even availability, but safety. Are there grocery stores that are close? And not just like small mini mart, but do they have fresh produce? Is that available? Is it safe to go there? How far is it? Does the patient have the resources needed to get there? Do they have the resources needed to buy fresh produce compared to processed foods? So all of those things. Social determinants of health, as you can see there in that final point, are an underlying cause of today's major societal health dilemmas, such as obesity, heart disease, diabetes, depression. Those are just a few. This is not an exhaustive list, as we know. So this is a schematic of some of the components that we consider with social determinants of health. And you can see here, and we'll talk a little bit more about these, but the neighborhood, health and healthcare, social and community, context, the education that's available, economic stability, and then here as well, just another way of looking at it, economics, food, education, healthcare, social, and environment. So let's talk a little bit about some of those. So some examples of social, the context of social. aspect of social determinants of health. And I won't go through all of these because, gosh, we could have, a 3-hour lecture just on the components of the social determinants of health and the role that they play. But just to look at a few of them, and I'll ask you to read these on your own. And, this is not an exhaustive list, but just in considering the things that influence our patients' health. What is their access to educational, economic, and job opportunities, right? All of those things have a huge impact on their well-being, their quality of life, their overall health. Availability of community-based resources. Think in terms of across the lifespan. The availability of preschool, the public health, the public school system that's available, any after-school programs for adolescents and teens, resources for adults, safe places to engage in recreation or exercise for the older adult, resources in the community that can help them if they're homebound. How do they get their groceries? What if they live on the second floor and they have an issue with their hip that needs to be replaced? How are they going to get to doctor's appointments? Are there resources for transportation? Okay. Things such as this. What about exposure to crime, violence, social disorder within that area? Even something that may sound benign but isn't, such as, is there a place to take the trash and that the trash is picked up and taken away? So lots of things to consider under the social aspects. Physical aspects. Are there green spaces? What's the weather like? Is it even possible for somebody to get outside, or do they have cold weather where they live for 6 months of the year? So that can be a determinant or an influencer of health. Just geographically, okay, that would influence the weather, but then also, on a smaller scale, what's it look like? Are there a lot of buildings? Are there sidewalks for them to walk or to safely ride their bike? What type of road system do they have? What type of repair are those roads? Now, that's not something that we would generally ask a patient, what are the road conditions where you live, but it's just something for us to consider, right? To be aware of. What's the housing and community design like? That we may ask, right? If we're sending somebody home and they need a certain type of care, we may ask what their housing is like. If they've just had a total knee replacement, we're going to want to know, what's your housing like? Do you live in an apartment on the 3rd floor? Do you live in a house that has 2 levels? Do you have to use the stairs? That sort of thing. Are there physical barriers, particularly for people who need accommodations or have disabilities? Is there good lighting? Are there trees, etc.? We know that these things affect health. Here's some more examples that are broken up into the actual subcategories. So things that have to do with the neighborhood, environmental conditions, the quality of housing, etc. Health and healthcare. What's the access? What's the health literacy of the person? And community. Social and community. Is there civic participation? Are there areas of discrimination? Is there a component of the population or a large component of the population that's incarcerated? Is there social cohesion, or is there social isolation within that community? Education, when I talked quite a bit about this before, and economic stability. Is there food insecurity? Is there housing instability? Is there poverty? All of these things we know affect um, the health of those who are in the community. This is a slide and a resource for you if you would like to look more into social determinants of health. And again, this was just a very brief explanation of one of the special considerations or the special assessments that we consider in the health of our patients. But there's so much more information out there. So I would encourage you to save this slide, to jot this down, and to look a little bit more into this particular topic. All right, changing gears completely, and now we're going to talk about the nutritional assessment. I'm going to go through this really quick because we talked about it under the complete health assessment. But this is another kind of special assessment. It's a 24-hour recall. Sometimes we use food diaries, particularly if there's a symptom that we think may be food related. So it may be an allergy. It may be headaches. It may be a rash. Whatever the situation, a food diary can be very, very helpful. It could also be with weight management that you would do a food diary. A more comprehensive nutritional assessment would include measuring nutrients, like doing the nutrient analysis. And that's pretty specialized. We generally don't do that in primary care, although we might loosely do it where we look at sort of what kind of carbs are they taking in, what kind of protein, what kind of fats are they taking in. Particularly perhaps maybe somebody who you're doing a food diary for a diabetic, and you might want to look at the ratio of the carbs to protein to fat. But anyway, that can be a component of a nutritional analysis. And then we may also include the anthropometrics, so assessing the height and weight and the body mass index. This is the food pyramid, which you're probably familiar with. I'm just showing this to you as a resource. This has changed dramatically over the past several years. And for example, this red meat has moved from being farther down here way up to the top. And so you can see now for a healthy food pyramid, actually the bottom is daily exercise and weight control. It's become increasingly more important. And ironically, our population is becoming increasingly more sedentary and overweight. So you can see that the best of the best are the plant oils and the food grains. That's the whole grains. That's what we should consume the most of. And then sparingly would be red meat and saturated fats like butter. And then some of the quote unquote white foods, white rice, white bread, white pasta. It's not that rice, bread, or pasta are bad, but those choices are better choices if we use brown rice, multigrain breads, whole wheat pasta, etc. And soda and sweets. We know that soda is really bad for us. That's one of my topics that I could get on a soapbox with. Soda's so bad for you. It just really is. There's really no redeeming qualities in soda at all, or pop, whatever you want to call it. And of course, we know that sweets need to be in moderation. But here's the thing. Here's the thing with soda. And I am going to spend just a minute on this because I think it's so important. For those of you who drink pop, just bear with me because I know not everybody wants to hear this topic, but it's important. It's important because I care about you, and it's important because I know you're going to care about your patients. So here's the thing. Diet soda came out, and we thought diet soda was like going to be the, people can drink pop now. It's diet. There's no sugar. It's good for you, right? Diet pop is good for you. No, it's not. So here's why. Well, one of the reasons is because the carbonation is bad for your bones, all right? It can leach some of the calcium out of your bones, and so the more you drink, the more damage potentially you can do to your bones. So carbonated drinks are not great for your bones. But then with the diet drinks in particular, what we found is that those artificial sweeteners can actually still trigger release of insulin. Your body doesn't necessarily recognize that it's not really sugar. It tastes sugary, that's not why the insulin's released, but the artificial sweeteners can cause a release of insulin. The insulin gets into your system then, and it's looking for sugar because its job is to convert sugar into energy, right? To break it down and convert it into energy. It's not there because it's an artificial sweetener. So now you've got higher levels of insulin, and there's not sugar for it to act on. So that triggers your appetite because now your body says, oh, gee, I've got all this insulin floating around. I need to do something with this. So that means I need to take in a food source so that the insulin has something to work with. So increasing your appetite then usually causes obviously more eating and not always good food choices. But what they found is that contrary to the belief that diet soda helps you to lose weight, people who drink a lot of diet soda actually tend to gain weight because they have higher insulin levels released, and then they end up eating more because they have this ravenous appetite. So I'll leave it at that, but there's a reason that soda is on the top of the food pyramid. If you consume soda, please do it so sparingly. This is a resource for you that can help you teach your patients about healthy meal planning, and particularly how to distribute components like fruits, vegetables, grains, and proteins, and quantify it. And then this is just a further explanation. I won't go through all this for you because you can read it, but it gives you more of an explanation on healthy meal planning, and that might go along with your nutritional analysis. So the anthropometrics include BMI interpretation. Most of us, if not all of us, are familiar with the concept of BMI, and that BMI stands for your body mass index. It's calculated by using your weight times your height in inches, and there's a graph that we use, a scale that we use. The interpretation is for adults, as you can see here, underweight is below 18.5, normal is 18.5 to 24.9, overweight is 25 to almost 30, and then greater than 30 is considered obese. Interpretation for children is different, so for those of you who will take care of kids, just recognize that the interpretation of BMI is a little bit different. And so children, we look at where they fall on the percentile, so comparing their height and weight per age compared to other children, their age. And so above the 95th percentile is considered obesity in children, actually up to 19, which kind of surprises me. I would think that would stop like somewhere around maybe even 16 or 17, but for now it's still for 2 to 19. And so there's an example down here of what that might look like. Here's another resource for you from the CDC, looking up healthy weights. It gives you some charts and that sort of thing. And then this is a BMI chart. And so if you've not used the chart before, because a lot of times in the EMRs, this just automatically does it for you. You don't know you don't have to know how to do the calculation. But if you have to use the chart, you literally just look up the height on one axis and then the weight on the other and see where that coincides. And so it gives you, the numbers, and obviously as the numbers go up past 18, you get into overweight, and then you get to obese towards the other end of the scale, greater than 30. This is just to show you sort of the trend, and I know you know this, but this is a visual representation. In 1990, there were actually states that recorded overall not having any issues with obesity. There were some that were, there's always some within a population that is overweight. But in terms of obesity, so a BMI greater than 30, there were some areas that had none. By 2000, starting to change. We're seeing more overweight and more toward moving toward a larger percentage, almost a quarter. When you get up around this level, the tan to the red, quarter of the population that would be considered obese. 10 years later, it hurts my heart to see this trend. It really does. Still more areas that have a greater percentage of the population that's obese. This is in 2019. So just a couple years ago, 50% of the population, like look at these states that have 50% of their population that's obese, a BMI greater than 30. I mean, think about the health consequences of this. This is astounding. And then this is the projection. 60%, it's projected, look at all of these states here. All of these states and around here are projected to have 60% of their population that has a BMI of 30 or over by 2030. We got to do something about this. This has to be something that we're talking about. It's uncomfortable. It's hard to tell a patient, I'm really concerned about your weight, but we have to. It's their health. It's their longevity. It's their children's health. It's important. We have to talk about this. Childhood obesity rate. This is what it is currently. I don't care for children, and I mean give care, provide care. I do care about children. I do care about them. I'm an adult nurse practitioner, so I don't provide care to children. But still, this just really, it hurts my heart, like I said before, because these kids are starting off behind. So 13.4% of 2 to 5-year-olds are obese. By 12 to 19 years old, more than 20%, more than 1 out of every 5 kids is obese. This is laying the foundation for them to have heart disease, to have high cholesterol, to have diabetes, to have pulmonary issues, to develop cancer early in life. So, oh man, we've got to be better. We've just got to be better. Racial and ethnic disparities are important to recognize as well, because the rates of obesity are even higher among certain ethnic groups. 25.6% of Hispanic children are obese. 24.2% of Black children are obese. Risk factors. Moms who are overweight, obviously that directly affects the fetus, but then it also affects the children as well. If the mom smoked, they're linked to children having a higher BMI. Overweight fathers, also higher risk for the children to be overweight. Prolonged bottle feeding can lead to the babies having a tendency to be more overweight, and a lack of physical activity. And that makes sense, right? That's intuitive. Just one more graphic. This shows high school obesity by state. And so it just gives you a visual indication of what we had just talked about. Okay, so moving from nutrition and obesity, we're talking now sort of on the opposite end of the spectrum, which is eating disorders and those that want to be exceptionally thin or may be exceptionally thin. So anorexia or bulimia particularly. The SCOFF is a screening tool that can be used. It's pretty easy. It's a 5-question tool that focuses on detecting patients that are at high risk for an eating disorder. And anytime we use these screening tools, it's really important that you understand what they're indicated for, so what you're actually going to learn. So this doesn't say that you are diagnosing an eating disorder. Okay, so if they score on this high, it doesn't say yes they have anorexia or yes they have bulimia, but it says that they are at high risk, which means I need to do some more investigation, or I need to call in another professional who can help me to assess and help this patient. SCOFF is an acronym for Sick, Control, 1, Fat, and Food, and I'll show you the questions. And again, it's not diagnostic. And here is a resource for you if you'd like to look into it more. So, do you make yourself sick? So, induce vomiting when you feel uncomfortably full. So that's the S. The C, control. Do you worry that you've lost control over how much you eat? Have you recently lost more than 15 pounds in a 3-month period? And again, this needs to be in context. If it's somebody who has been watching everything that they eat and they have a healthy diet and they've been exercising because they recognize that they were in the overweight BMI range and they wanted to lose weight, well, okay, that's different than somebody who's already at a healthy BMI and still trying to lose weight. So put that in context. Do you believe yourself to be fat when others say that you're too thin? Would you say that food dominates your life? So do you think about it? Does it does food influence decisions that you make? Where you go, what time you go, how long you're there, what you do while you're there? Do you find yourself sort of ruminating, or you don't want to say obsessing because that has such a negative connotation, and we want to use neutral language if possible. But getting at this question. Would food dominate your life? And they get 1 point for every yes. And a score of 2 or higher indicates that we need to look into this more because they're at risk for either having anorexia or bulimia. Some considerations as far as nutrition in the geriatric patient. We know that physical changes affect nutrition, not only how they can eat, do they still have their teeth, can they taste it, is their mouth dry, do they have problems swallowing, but also how they glean the nutrition from the foods that they do eat. Their GI system may not work the same. They may have constipation. They may have had other GI problems or illnesses or surgeries that affect the way they actually can break down and use the nutrition that they do get. Body composition is different as fat replaces muscle. Decrease in lean body mass, their BMR declines 5% per decade, which is really kind of frustrating and sad because we all know this, right? That a 15-year-old boy, if you compare a 15-year-old boy to a 30-year-old man and they eat exactly the same thing, the 30-year-old man is most likely going to gain some weight from a high-calorie diet where the 15-year-old boy may not, because of the BMR. Because the BMR starts to decline actually when we're in our 20s and 30s, and it declines 5% per decade. And so we just don't burn up the calories as quickly or efficiently as we did when we were younger. So the total caloric need drops, but the calories that they take in need to be dense nutritionally, and sometimes that is a challenge. They have lower protein reserves, which slow the body's ability to respond to injury or surgery. We know that they just don't heal the same. Body water decreases along with the decline in lean body mass. Okay, an exercise assessment we might do, and we will do a form of an exercise assessment in one of our screening tests as an assignment. And so there are several different ways that you can assess exercise. It can be, just simply asking questions. Is it planned exercise? Is it sporadic? The number of times, what they do, how long they've done it, that sort of thing. It can be more specific, like determining the METs, which is a little bit beyond what we're going to do, but just so that you will have heard some exposure. And METs are metabolic equivalents in exercise testing. It's how much you burn, how much your body expends in terms of energy, and their exercise prescriptions. And then there's this Duke Activity Status Index, which is what we are actually going to do. Now, this is more of an indication of functional capacity, the Duke Activity Status Index. And so you'll see when you get the form that you look at some of the things that they can and cannot do, and then they are assigned a score, and you do a calculation, and that gives, like I mentioned, this functional capacity. It's the peak oxygen uptake, and so the lower that is, that means the lower their functional capacity, and actually scores of less than 15 are transplant candidates, and greater than 20 shows little to no impairment in functional capacity. So that's how you'll record it. It's because it's measuring functional capacity. Another type of special assessment is a pediatric assessment. And pediatric assessments, well, they're highly specialized, and those of you who are going to do family practice and those who specifically will care for children, you will get much more of this in some of your specialized classes. But just as a very brief overview, the pediatric assessments correspond to their developmental stage. It's a way that we look at their development, right? So there are predictable pathways according to the child's age, certain stages and tasks that they should be able to accomplish, governed by the brain development. There is often a very wide range of what is considered normal, particularly for the younger kids. We know that the physical, social, environmental, and if they have other diseases, that affects their overall health, and so that's taken into consideration when we're looking at their development. And we also know that their developmental level affects the history and physical exam that we're going to do. So in other words, there are some tasks that we might ask a 3-year-old to do that we wouldn't expect a 6-month-old to do, or a 10-year-old to do that we wouldn't expect a 5-year-old to do, right? So we put it in context and ask for what is developmentally appropriate. So age dependent, the things that we consider, the physical development, right? So a 1-year-old is going to have a different kind of physical development than a 10-year-old. Same with cognitive development, social and emotional development. Anticipatory guidance is going to be different depending on the child. And when they're younger, the anticipatory guidance would be geared more toward the caretaker, the parent, the guardian. But as they get older and they move toward pre-adolescence and adolescence, then some of the anticipatory guidance shifts, and we give that directly to the kids, right? So as they get in pre-adolescence and adolescence, we may start to think about, well, what are some of the high-risk behaviors that they could possibly get involved in? And we start talking about those things. Violence, gun safety, perhaps drugs, alcohol, sex, texting, social media, sexting, and so staying current with like the trends and the issues that affect children is really important to those caretakers who are going to be caring for the children, and then obviously knowing what's normal and abnormal by knowing the developmental stages. And as I mentioned with adolescent assessments, it changes, right? Because there are special considerations for the young adult, the adolescent. So special questions for special situations, with or without the guardian there. And so this may be, asking a 14-year-old, hey, are you aware of anybody, in your set of friends that is drinking alcohol? Well, do you ever drink alcohol? Anybody who does drugs? Have you ever done drugs? Do you use drugs regularly? And again, non-judgmental, same way that you'd ask, do you like chocolate chip cookies or oatmeal cookies? You keep that tone. You are aware of your nonverbals and your body language, and you ask. Same with sexual activity, so that we can identify areas of risk, we can educate, and we can do anticipatory guidance. And sometimes, for parents who have difficulty approaching these decisions, if a medical provider brings them up, it opens the door for them to have conversations later. And so even though it can be a little bit uncomfortable, a little awkward even for us, and the parents may or may not say anything to us about it, they may say, oh, not my daughter, not my son. Okay, that's fine. I still have to ask because I treat every patient the same. It may open a door for them to be able to talk. And we know that these things happen. And so we, again, don't want to draw conclusions or make assumptions, but we always ask. Here are specifically some things that are recommended to ask adolescents if you see adolescents. And the acronym is HEADS. So how are things doing at home? And these are things, you can ask as you're doing your physical or whatnot. And, you're just having conversation, right? But it's, from your point, it's an intentional conversation. How are things at home? How's school going? Do you like your subjects? What classes are you in? How are your grades, right? So we get at education, activities. Well, what do you do for fun? What are your recreational activities? And then you can also get a gauge for, what is their affect? What is their ambition? Do they have goals? Are they angry? All right, that's A. D is drugs or substances. And again, I mentioned that on the previous slide. Getting around at, do you use drugs? Do you drink alcohol? Does anyone in your family? And then S is sex. Are you engaging in sex? Are there any sexuality issues? And with adolescents, you got to be really specific. And you may not be able to sort of just ask, are you engaging in sex? But you may need to be very specific. Like, there are a good number of adolescents who don't consider oral sex, but there are still risks that come with oral sex. They can still get gonorrhea and chlamydia. They can still pass HPV. They can still have yeast infections and spread yeast infections. So you need to ask. The same is true with anal. So we've got to ask these questions, and they may be embarrassed, and you just try and normalize it as much as you possibly can. But if you don't ask, they're probably not going to tell you. And then the geriatric assessment. Some things to consider go along with what we had talked about earlier, so I'm not going to spend too awfully much on this slide, but just recognizing some of the larger areas: their physical health, their overall functional ability, their psychological health, and social and environmental parameters. Now, there are some specialists, geriatric specialists, who will do a comprehensive geriatric assessment. So if you have a frail elderly patient who needs a comprehensive assessment, looking at everything: cognition, physical, social, to see where they're at, identify any deficits, and come up with a plan to maximize their health, keep them safe, that sort of thing. If you have this kind of practitioner available as a resource, I highly recommend, if you're taking care of the older adult, that you do take advantage of this resource, because they are fantastic. Now, these evaluations, you want to tell the patients ahead of time. They will probably want to take somebody with them. There's usually a family member that goes with them. And they are long, like hours, because they do, as it says, a comprehensive assessment. They do all kinds of cognitive testing. They do physical examinations. They check endurance. They check flexibility. They look at a lot of stuff and get a very good overall picture of the functional abilities and the deficits that that older adult may have. The framework that it's based upon, you can see there. It's very much a team approach. It's multidisciplinary. That's what allows it to be so comprehensive. And it's not just a one and done type of deal. But once the patient is evaluated, then there are periodic evaluations to make revision to the treatment plan as necessary. This is an example of just a general screening tool, and this came from UpToDate. I know we don't readily have access to UpToDate through school now, which is really unfortunate, but you don't need to be able to read all of it. I just wanted to put something up to show you that there are those resources available. And as you can see there in the middle, these are the components: the functional status, visual impairment, hearing impairment, urinary incontinence, malnutrition, if it's there. It probably should be more neutral and just say nutrition. Gait, balance, falls, depression, cognitive problems, environmental problems. These are the components that are the minimum components that should be included in a screening of a frail older patient. There are also tools, and this is in particular an algorithm for fall prevention, because we know that older adults become more at risk for falls. And so some of the things to consider are, for example, your first 3 screening questions are, does this patient have 2 or more falls within the prior 12 months? Are they presenting at this visit with an acute fall? Do they have difficulty with walking or balance? If they answer yes to any of those, then you go down this side of the algorithm and you do a very thorough evaluation to assess for risk. If they don't, then that takes you down another side of the algorithm. But just so that you know that that is available, and if you're taking care of older adults, this would be a really good resource to have on hand, so that you can go through it if you do have a patient, say, who comes in with a fall, or they come in with something else, but you see, oh, look, they've got a big bruise over their right orbit. Tell me what happened. Oh, I stumbled in the shower the other day. All right, well, now we've got 2 things to take care of, right? We need to assess their risk for future falls, and we need to take care of the actual issue that they came in with. So this would be a really good resource for that. Okay, in essence, we're asking why. Why? It's the pesky Y chromosome. These are just some things to consider as we see our patients, some additional screenings, and some additional why questions that we should have answered. Okay, if you need to take a little break, you can take it now. If not, I'm going to move into mental status, and we're going to cover this very briefly. So, assessing mental status. This is the person's emotional and cognitive functioning. There are all kinds of tools, from just simply asking about orientation and making sure that the patient is oriented and appropriate for the context and situation, to doing screenings. So there are all kinds of ways that we can gather this information. Most of the information is through the history, physical exam, and the psychosocial history. We look at the patient, their appearance, their grooming, their behavior. So do they seem depressed? Do they seem anxious? Are they crying? Is it appropriate though, right? So you put all of these things in context. Some of my patients cry. That's completely appropriate. If I'm in primary care though, and the patient's coming in I don't know, for a diabetic check and they're having crying spells. That's not appropriate to the context of the visit. And so, okay, that's a different finding in a different situation. Other things that we, consider, their motivation. So, are they having a hard time getting out of bed? Are they angry? Do they have suicidal thoughts? Are they doing their ADLs? That sort of thing. But it's important to assess mood. And unlike cats and dogs, we can generally see differences in the moods of our patients. So, other than moods, we also want to look at cognitive abilities. So, orientation to time, person, and place is an easy way to do it. We can also look at memory, and that includes past and recent, their ability to make judgments, their ability to reason and do abstract reasoning. These are all components of some of the screenings that are out there, and a couple in particular that we will do, I believe it's next week, and with our screening test. Now, another thing to remember, and I've mentioned this before, with any screening tool, know what it measures. So in other words, you may do a screening tool that shows that there's either no cognitive deficit or a cognitive deficit, but it doesn't mean that they have dementia, okay? So if you get a score that shows a deficit, you can't say, this shows the patient has dementia. No, this shows that a score of X translates to a mild cognitive impairment, okay? So be sure you know what the test measures and that you're recording it as such. Also, be sure that the test is appropriate for your patient. And in particular, in the patient's ability to understand. So if it's a test that is self-given, so you give it to the patient reads it and does it, can they read? Is their reading level high enough so that they can understand it? Is English their primary language? And if not, do they understand English enough to be able to read it and understand it? And then in terms of understanding abstract reasoning, this is very culturally based. I mean, some of the sayings that we use is even geographically based within the United States. You hear some sayings in some parts of the country that in other parts of the country, sound like they're ridiculous. So you kind of have to take all that in context too. When we're assessing abstract reasoning, it may not be that they don't have abstract reasoning. It may just be that they don't have the context that's needed to be able to answer the question. So like a bird in the hand is worth two in the bush. If we ask somebody that, doesn't speak English as their primary language, well, what does this mean? That may mean nothing to them, right? So keep that in mind. Okay, a couple examples of tests that we're going to do. The Mini-Mental, most of you are probably familiar with the Mini-Mental. It's a standardized screening tool. The maximum score is 30. Depressed clients, even without dementia, can score somewhere between 24 to 30. So what that tells us is that, there are some patients who may not have dementia but do have depression, and they're going to score lower on the test. So that's one of the reasons that we can't say a lower score on the Mini-Mental means that they have dementia, right? A score of 20 or less is found with several conditions. It can be dementia, delirium, schizophrenia, or an affective disorder. So again, it's not diagnostic. It's screening for risk. The MMSE looks at age, education, it's affected by age, education, environment, cerebrovascular risk factors, and even the mental health conditions, and some behavioral factors. So it's not a perfect test, but it's a good screening. It's intended to be a screening, and that's what we use it for is screening. MoCA, this is different. So let me just say one more thing about the MMSE. You'll get the MMSE form. You'll be able to fill it out. It has the scores and what the scores mean on the bottom. So just be sure that you're not recording it as that they have dementia, etc., that it's, do they have a deficit or do they not have a deficit? Okay. The MoCA. The MoCA is a little bit more specific. So the MoCA is the Montreal Cognitive Assessment. It's brief. It takes about 10 minutes to do. And it screens for mild cognitive impairment. But this can detect people who score in the normal range for the MMSE. So it's a little bit more sensitive than the MMSE, all right? The MCI is a risk factor for dementia, and the normal score is somewhere between 26 and 30. Lower scores, again, don't mean dementia. They just show some impairment that then would clue us in to the fact that we need to do a more specific, more in-depth assessment. And when you do the MoCA, you're going to see it's fairly involved. And here are some of the components. So it's going to check orientation. It's going to check short-term memory, because we're going to ask, we're going to tell the patient a few words, and then we're going to ask them to repeat those words right after we say it, and then we're going to ask them to repeat them a few minutes later. It's going to check some executive functioning, like their ability to write, to copy a three-dimensional picture, their language abilities, so we're going to listen to them speak, and understanding is abstraction. Attention, this is like spell world backwards or count back from 100 by 7, and they do their serial 7s. Animal recognition and naming, or they look at a picture, translate that, and then assign the correct word to it. So, it seems kind of easy to us, but actually there are several processes to seeing a picture and then translating that into a word and speaking it appropriately, and then a clock drawing test. So that's an overall view of the MoCA. Okay, so we've done special assessments, we've done mental assessment and screening. Again, the last question of the interview before you leave, and sometimes this gets us a little bit, but we still always ask, do you have any other questions or concerns? Okay, and sometimes this is with our, hand on the door, and we're about ready to leave, and the patient says, "Oh yeah," and it may require us to sit back down and to follow a little bit of a different path to find it out. There's some patients who it takes almost the whole interview before they feel comfortable to ask us that sensitive or difficult question, and then it comes at the end. But we want to give that as much attention, because usually I won't say usually, but oftentimes that's the real reason that they came there. So, and I've had this happen, and I've had it happen with some sensitive issues. I had a patient who I saw, and this was a little while ago, but he and his wife were there, and he was in for, it was either diabetes or hypertension, but it was just for a routine check. And things were going okay, and I did his assessment, and, to his heart and his lungs, and renewed his prescriptions, and he was doing really well, and I thought we were done, and I said, "So do you have any other questions or concerns?" And it was actually his wife who said, "Yeah, actually he does." And usually when the wife answers for the husband, it's something that's kind of sensitive, and he doesn't want to bring it up. And I said, "Okay, so won't you share with me what your concern is?" And he was having some challenges with erectile dysfunction, and not just erectile dysfunction, but when he would have an erection, he had pain, and he had noticed that he had some deformity. And so I thought that we were done with the visit, but that was actually the real reason that he wanted to come in. So we had to go down a different route there and thoroughly evaluate that, and he ended up going to urology because he had developed some fibrotic tissue that needed to be taken care of, but it could be taken care of, and it could increase his quality of life again. But it was the final question. Do you have any other questions or concerns? So That's an important one. Don't forget that question, but be prepared when you ask it, because sometimes they truly are gonna have other questions and concerns. All right, that is the end of this lecture. We have one more lecture in this series where we'll talk about a few special interests